First of all, thanks to the organisers for giving us the opportunity to come and talk to you about this programme, and thanks to Dominic for that good setup for us to demonstrate how we can create culture change in the flash of a wand. Glyn's already been introduced, but I do want to introduce you to the two other members of the panel here, as it were. Helen McGarrigle, who's a specialist nurse working with the breast cancer team in Cardiff, and our own medical director and medical lead for this in Newcastle, Sheila McPhail. And they'll be able to, we wanted them to be part of this so that they can give you a sort of a real grassroots sort of response to any of the questions you might have of us as we talk through what we've done and achieved over this period. We're going to split this up a little bit in the same way that Dominic did earlier today, which is to give you a bit of the story and then open it up for some comments and questions. So I'll start off with giving you sort of a helicopter overview of what it is we've been trying to do. We'll open it up for a few comments and questions at that stage. Then Glyn will talk about one specific depth example in the breast cancer team in Cardiff to demonstrate how we've progressed in one particular area, and we'll have some questions after that. And then I'll talk about the sort of breadth issues, some of the learning that we've got from some of the other settings that we've engaged in this. You already know, and I won't need to reiterate this, that this is a collaboration between Newcastle and Cardiff and funded by the Health Foundation in the UK, which is a major charity that funds quality improvement and implementation work. So this is an implementation project, it's not a research project. And there are many acknowledgements that we need to make, but most importantly the clinical teams and the patients and others that have been involved at a local level in helping us to work this through. You already heard yesterday from Steve that in the UK and the NHS, with at least one crude measure, we don't appear to be doing very well in engaging patients in decisions about their care. So there is a challenge to us. What we set out to do within this MAGIC programme was to develop an implementation approach over, initially, as Dominic has said, 18 months, that would enable us to understand what we need to do to take, if you like, the evidence that we already have about the effectiveness and value of shared decision making, but actually get it into grassroots, on the ground practice, actually have it happening in clinics, in that consultation, and within the clinical teams. In order to do that, we selected a number of areas across both Cardiff and Newcastle that would provide us with a range of experience. So we've got secondary care and primary care. We've selected some areas where the approach has been hooked around a decision tool. So in urology in Newcastle, we've used an NHS-based patient decision aid for lower urinary tract symptoms. In breast cancer in both Cardiff and Newcastle, we've used the Bresdex tool that Glyn's team has developed. But in other areas, we've taken an approach that's more around trying to get this embedded across a team or across an organisation. So in primary care, what we've tended to do is, rather than go for a specific tool, is work with general practices as discrete individual organisations and try to get them, as they've described it in Newcastle at least, become MAGIC practices. So it's about changing their behaviour, not by throwing a decision aid at them, but by supporting them in thinking differently about the consultation, if you like. And in somewhere like obstetrics, it's been a bit of a mixed approach, where we've, in some settings, used decision support tools. In others, we've gone into new clinical areas, and we'll talk a little bit about that later on. So there was that sort of mix, primary, secondary, tools or not tools, organisation-wide versus a specific clinical decision. We also said, well, if we're going to talk about implementation and change management, how do we put together a multifaceted approach that's likely to lead us to the sort of changes we're trying to implement here? And this is the sort of thing that you might use at the end of this session when you reflect on the models and frameworks that you've had presented to you yesterday, as to how this fits along those lines. But so we were starting off with, if you like, evidence-based patient decision support and evidence-based shared decision making. But in order to try and make that work in practice, we had several components to a change programme. First of all, we introduced a process of social marketing. So raising the profile, spreading awareness. Magic itself, as Dominic said, has grabbed people's imagination. So in itself, that was a marketing component right from the beginning. But we've also extended that into social marketing models, and we'll talk later about that in terms of putting questions out for patients that they might ask as they come into the clinical consultation. We've built a program of clinical skills development, and that's based around not only just developing knowledge and understanding, but advanced clinical skills, and how can we skill up people, clinicians, so that when they say to us we're doing shared decision making, they actually know what they mean by that. And we'll talk more about that today, and there's also an opportunity, I think, in tomorrow's lunchtime session where we'll be talking more broadly about education and training to pick that up as well. We've used approaches to organisation and clinical team engagement through the creation of clinical champions. So we started off with teams that wanted to be part of this. That doesn't mean they were doing it, but at least they were signed up to wanting to work with us on it. And where there was at least someone who was saying in that team, we'll be part of this programme. So we were working on the basis that you need to start off with some form of clinical champion to get something like this working. And we sought at the beginning to ensure that the organisations we were working with, whether it be a hospital or a health board or an individual general practice, were also signed up to wanting to do this. And then we've worked throughout the programme on what we know that ought to have an impact on the way that clinical teams or general practices behave, to try and emphasise that and to engage them further. Most importantly, perhaps, is an approach that's been an action learning approach, learning as we go along. We didn't have a set programme, a set project protocol that went from day 1 to month 18. What we did have and what we did know was that we needed to learn as we tried things out. So we were trying to use a rapid testing, quality improvement, action research, reflective feedback model. So for example, we have regular monthly meetings of the clinical teams and clinical leads and a local design team to say what's worked, what hasn't worked, what's worked for you, can we share good practice? If that didn't work, what can we do differently in the next month or the next couple of months? So very much that sort of reflective model. And also, last but not least, seeking to weave throughout this programme a component of patient and public engagement. Part of that through things like the 3 questions approach to patients, but also having patient and public involvement panels in both sites and listening to them and being challenged by them in the way that we approach this. So that's really the sort of the framework that we've adopted. And